Should we start?
Yeah, sure.
So, are you ready?
Yes.
Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 14K, which is Hematology General and Fundamental. We are streaming live from Suraksha Diagnostics, Kolkata. And in continuation with our Flowcytometric teaching process, we have a very interesting topic today, Flowcytometry application in Hematology. This is session 1. And to talk on that, we have somebody who is an expert. We have Dr. Gopal Bhagwat. He's an MBBS and MD from R.D.Gardi Medical College, Ujjain, with a PDF in laboratory hematology from the famous Tata Medical Center, Kolkata. Presently, he is a consultant hematopathologist at Suraksha Diagnostics, Kolkata. He is a section director of hematology, immunohematology, and flowcytometry at Suraksha. Dr. Bhagwat has received his fellowship in laboratory hematology from the prestigious Tata Medical Center. During his training, he acquired organized and structured hematopathology reporting skills and foundational knowledge to improve patient care. He also had a 1-month hands-on training at the University of Salamanca, Spain, where he gained experience in flow cytometric analysis of various hematological malignancies and MRD analysis. In 2019, he received the Behind Travel Award at the annual conference of the ISLH in Vancouver, Canada. He has areas of interest in hemato-oncology and flow cytometry. Before I ask Dr. Bhagwat to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Gautam Bhagwat, sir, please share your screen and let us start.
Yeah, good. Am I audible?
Absolutely clear. We can see you clearly, right?
Presentation is visible, right?
Perfectly fine.
Okay. So, good evening, everyone. And once again, I would like to thank Dr. Nadeem for giving me this opportunity to talk on flow cytometry throughout the entire three sessions. The first one was around 1.5 months ago, in which I talked about the basics of flow cytometry, in which we went to through the fluidics, the optics, and the electronics of flow cytometry. I have the luxury of having two back-to-back sessions, one today and one day after tomorrow, for the applications of flow cytometry in hematology. So I have divided my two talks. This one would be basically focusing on the malignant hematological diseases, or the hemato-oncology as we say it. And the second session would be mostly on the benign diseases of hematology, in which flow cytometry is being used. So just run through with the basic of flow cytometry that I had taken in the last talk. So flow cytometry measures properties of cell as they flow in a fluid suspension across an illuminated light path. So what happens basically is, we through a flow cell, the cells go in one single file, and these cells are interrogated by these laser light at this point, and according to the inherent properties or the antibodies, the fluorescent label antibodies attached to the surface of this cell, the light is scattered into various pathways. The forward scattered would be measuring the size according to the size. The side scattered would be according to the granularity or the complexity of the cell, and based on the fluorescence emitting wavelengths of the various labeled antibodies, these would go through this mirror and would get filtered and would be detected by the photomultiplier tubes. All these photomultiplier tubes will send its signal to this analog digital converter, which will convert these signals and send it to the analysis workstation, where the doctor or the technician would analyze the plots and the graphs and the values and come to a diagnosis. So sample labeled with fluorescence antibody, these emits the light which is detected by photomultiplier tubes, and the analog fluorescent signals are converted to the digital signals. So in short, this is what the flow cytometry machine does. So what kind of samples do we get in the hematology lab? Routinely we get the peripheral blood and the bone marrow, because this is the cell suspension that would carry most of the hematological diseases. Apart from peripheral blood or bone marrow, there are certain other fluids which we can receive, because the malignant tumors tend to go or to metastasize to these organs. So for example, in CNS, the choice of specimen would be a CSF. The malignant cells can go to the pleural cavity, the pericardial or the peritoneal cavity. So we would get the pleural fluid or ascitic fluid for detection of these malignant cells. ALLs might go to the intraocular fluid or the vitreous fluids, so we can get that specimen also. Malignant tumors or lymphomas around the pleura or lung, we can get a bronchoalveolar lavage done to detect the cells in that fluid. FNSE material can be suspended into a media to form a cell suspension, and this can again be used for processing of the flow cytometry. And as we are talking about the lymphomas here, so lymph nodes are the organs which would have this disease. We can get the tissue biopsies or lymph node with a specialized instrument. We would tease these lymph nodes, and we would create a uniform cell suspension, and thus we can do the immunophenotyping by flow cytometry in the lymph nodes by making a cell suspension and running it through a flow cytometer machine. So coming to the analysis, what are we analyzing? As I have already mentioned time and again, but this is what I want to emphasize again and again. Size is forward scatter, granularity is side scatter. These are the inherent properties of a cell and definite markers for these cells. And then there are definite markers which are either surface markers or present in the cytoplasm or on the nucleus. We label antibodies against this antigen and detect this. All these come and gives me the cell characterization. This is what basically we analyze, and every cell has its own character. in terms of the size, the granularity, various antigens present on the cell. So where do we use flow cytometry in hematology? So the most important is the diagnosis and subtyping of the lymphoproliferative disorders and leukemia. Then would be detection of residual disease, that is the measurable residual disease. We can do DNA ploidy analysis. CD34 assays are important in patients who are going to receive bone marrow transplants. Lymphocyte subset analysis, primary immunodeficiency disorders, the paroxysmal nocturnal hemoglobinuria, platelet count, the gold standard according to ICSH is flow cytometry, and hereditary spherocytosis. So these are the various applications in hematology, as we would say it. Today's talk, I would be focusing mainly on these first three, that is diagnosis, subtyping of lymphomas and leukemias, detection of residual disease, and DNA ploidy is a part of this diagnosis or the follow-up of leukemias and lymphomas. In the next talk, the other applications I would go through. Apart from these, flow cytometry can be used for cross-match in various transplants, such as kidney transplant patient. You may there the flow cytometry cross-match holds great importance. Other than that, there are applications in autoimmune disorders, in sepsis, in solid tumor also we can do ploidy analysis, which is being used in some centers. But we would stick to the hematological application of the flow cytometry. And in 2016 we got this classification, tumors of hematopoietic and lymphoid tissues. We call it as leukemia and lymphomas. The classification was in two, myeloid neoplasms and lymphoid neoplasms. Myeloid, again, it was myeloproliferative neoplasm, mastocytosis, myeloid or lymphoid neoplasm with eosinophilia and gene rearrangements, the myelodysplastic syndromes, the AML, the acute myeloid leukemia and related precursor neoplasms, blastic plasma dendritic cell neoplasm, and acute leukemia of ambiguous lineage. Lymphoid neoplasms, the precursor lymphoid neoplasm or the acute lymphoblastic leukemia, mature B cell neoplasm, mature T and NK cell neoplasm, which we call as lymphoproliferative disorders, Hodgkin's lymphoma, immunodeficiency associated lymphoproliferative disorders, histiocytic and dendritic cell neoplasm. So this is the broad classification which was given in the WHO in the year 2016-17, and almost the flow cytometry can have an application in almost all these entities, but any diagnosis compromises of basically four things. One would be the clinical symptoms and the signs. The second would be the morphology. Third would be the immunophenotyping, and the fourth would be the DNA analysis. So few of the entities in this are better diagnosed with the DNA analysis by cytogenetics or by molecular methods. Few of the diseases are better analyzed by immunophenotyping by flow cytometry. Few of the disease entities are better diagnosed by immunophenotyping of tissue, that is immunohistochemistry. So as we are talking about lymphomas basically are coming from the lymph nodes. So in a lymph node, if the disease is not present in the peripheral blood or bone marrow, then it becomes difficult to do a diagnosis on flow cytometry, and in such situations immunophenotyping by IHC is a better option. Or for example, in a MPN or a MDS, a combination of clinical symptoms, morphology, and the molecular and cytogenetic analysis would give us the diagnosis. Flow cytometry would help in all these diseases, but usually we don't receive samples for all the entities. I would be going through the routine specimens that we get. That is the diagnosis of the entities for which we get in this talk. I would be keeping it very basic, but let me tell you, there are lots of papers, there is lot of research in which For each and every entity that has been mentioned over here, we have the flow cytometry markers, and people are doing flow cytometry for all these disease entities. But as I told, I would keep it basic to what routinely we get, as this talk is more directed for learning of the postgraduate students and the residents. I would go through the normal and routine cases rather than going into the rarer entities. So coming to the flow cytometry in acute leukemia, flow cytometry is the backbone of the WHO classification as far as acute leukemia is concerned. Now, what is acute leukemia? So, it is more than 20% blasts in peripheral blood or bone marrow, or presence of recurrent genetic abnormalities such as translocation 821, inversion 16, translocation 1517, etc. So, flow cytometry plays a big role in the classification. It has a crucial role in diagnosis, the lineage characterization, and subclassification of acute leukemia. Now, most of the postgraduates, we thrive to go with the try to make a diagnosis based on the morphology, but as we study hematopathology more and more, we tend not to give any diagnosis based just on the morphology, and we would just label an acute leukemia if we have blasts in our peripheral blood or bone marrow. We can do a cytochemistry analysis with MPO, NAC, PAS, etc. But nowadays, again, flow cytometry has taken over this cytochemistry. But any day, a hematopathology lab should have these stains, and which are very helpful in at least lineage characterization in a very economical way. But flow cytometry is almost the mainstay and has taken over the cytochemistry also. How does flow cytometry help in acute leukemias? It helps in diagnosis, it helps in prognosis. So there are certain markers which would give the prognostic value and would tell whether it is a good prognosis acute leukemia or a bad prognosis acute leukemia. Then there are certain predictive markers. So we can tell that or we can give out in our report that certain antigens are present against which targeted therapy can be given. So there are predictive markers. And then nowadays, MRD, or the measurable residual disease as we now call it, is very, very important in acute leukemias. And a long-term follow-up with MRD decision making on intensification of treatment or continuing the same treatment or knowing the chances of relapse, etc., depends on the measurable residual disease. So it is also very important part in acute leukemias. And flow cytometry, again, multiparametric flow cytometry is the mainstay of measurable residual disease detection in acute leukemias. Now, there are so many markers to be learned, and we all tend to mug up these markers, but it is my sincere advice that it would be much better if the students and residents go through the normal plots, that is the normal bone marrows which you would be getting, plus the abnormal or the diseased bone marrow. The more you see the flow cytometry plots, more you get accustomed to the markers, which marker is present in which lineage, and less it would be to mug up these markers. But at least a basic understanding is very, very important. So there are certain markers which are stem cell markers, certain are myeloid, such as MPO, 1333, etc. I'll not go in this. But knowing the knowledge of these markers is very, very important. Along with the knowledge of markers, it is also important which marker is present at what stage of maturation. So for example, this is the neutrophil maturation. Now, as you can see, if we presume this is the blast stage and this is the mature segmented neutrophil stage, then you would see these markers HLA-DR, CD34. These two are present only in the blast. The CD117 would be present in blast as well as promyelocyte. Then coming to CD13, this is an interesting marker. Initially, there would be presence of CD13, then the CD13 gets lost in the middle stages of the maturation. Then again from the metamyelocyte stage, you would find CD13 coming back. The CD16 or CD15 would not be present in the blast. They would come in the CD15 from, say, myelocyte stage, and the CD16 from the most likely metamyelocyte stage. So understanding of these markers become very important in terms of in which stage which marker is likely to be present. Similarly, if we say for the B cell maturation, TDT is a marker of immaturity present only in the initial stages of the B cell. Kappa lambda would be present after the pre-B cell stage. DR again present in the initial stages up to the mature B cell, and so on and so forth. So understanding of again these maturation patterns is very, very important, and I'll emphasize through one or two cases how these maturation patterns are used in diagnosis or in MRD or MDS, etc., for diagnosing all those disease entities. Next important thing is panel designing. Now, in 2008, we had Indian guidelines which had 4-color panel. So there would be a B cell tube, a T cell tube, a stem cell tube. But nowadays, 4-color panel is not being used, and it is almost outdated. Although I still feel a diagnosis can be made based on the 4-color panel, but yet, as I had mentioned in my last talk also, the more number of colors, the more parameters you can, or the more properties you can get to know of a cell, and therefore the more number of color tubes, and it becomes much more easier. Also, it becomes economical when we have more number of color, lesser number of tubes. So for example, you would see here CD45 is the backbone marker in this. CD45 is being used almost 1, 2, 3, 4, 6 times. But if I had an 8-color tube, I would have put these 3 markers, and one more marker from here alongside this, and CD45 would have been used only once instead of, or twice or thrice, rather than using it for 5 to 6 times. So you have to choose wisely, because the tubes are designed in such a way that you get the optimum result in minimum efforts and in the most economical way. Now, each lab can design their own panels, or the panels are available on in so many papers. And one of the panels which I got to know when I was in Spain, Salamanca, was the Euroflow panels. They have a very beautiful panel designed, and they have put in lots of efforts designing this. So this is the acute leukemia orientation tube. So the first tube that the clinical symptoms suggest that there are it is most likely acute leukemia. Morphologically, you see there are blasts. So they would first do the acute leukemia orientation tube, and in that they would get whether it is a B cell ALL or a T ALL or a AML MDS or a leukemia of ambiguous lineage, whatever, they would decide it at the very first tube, and then accordingly they would plan the further tubes. So this becomes an economical way to do things, and this is freely available everywhere, the panels. So this is the allot tube in which they have the markers based on the what WHO guidelines are for different lineages. Also they have the maturity or the stem cell markers, and you can get these tubes or you can create your own tubes, it is up to you. But while designing panel, just choose wisely so that everything is economical also and gives you the more maximum information also. So once the panels are designed, the antibodies are put on the cells are run through the Flowcytometry machine, and we get the plots and the graphs. So now what do we do next? So we have to make some gates. Now what is a gate? A gate is that we select our cells of interest. So for example, the first graph is forward scatter height versus forward scatter area. Now don't go into what area and height are defining, but we know forward scatter is directly proportional to the size. So all those cells which are present over here or over here, so these cells have more of a forward scatter, these cells have more of a forward scatter. So most likely these cells are larger in size, in terms of they are not single cells. So ideally from the flow cell, one cell should pass at one time, but it is not the ideal situation always, and you would get double cells going or triple cells going. So these cells would have a larger size, and therefore the first gate that we put it is around the cells which are singlets, and we call this as singlet gating. The second is the forward scatter versus side scatter. So these two parameters would give me information about the lymphocytes, monocytes and granulocytes. Granulocytes having the maximum size and maximum granularity, while lymphocytes having the minimum size and the least complexity or granularity. Also from here I can remove these cells. Now what are these cells? These are most likely the debris or the fragments of RBC which we have lysed. So on what basis are we removing this? So we know that these cells have a very low size, even less than lymphocyte, and we know that there are no WBCs in our peripheral blood which would have a size less than the lymphocyte. So we remove this debris and analyze only these cells. Once this gate is done, the next step is CD45 versus side scatter gate. In the CD45 side scatter gate, so side scatter is telling you the granularity, the myeloids having the most and the lymphoids the less. But here the difference is that CD45 is brightest in the lymphocyte. So if you compare with the forward scatter gate, in the forward scatter the lymphocytes were on the left hand side because they are smaller in size. But in the CD45 side scatter gate, the lymphocytes are on the right hand side. That is, they are the most brightest in terms of CD45 expression. Then these are the monocytes, these are the myeloid cells, and then there is this, the European people call this as the Bermuda triangle or the Bermuda zone, or these are the cells which we don't know what it is. Mostly the blasts, the basophils, the PDCs, etc. would fall into this area, which have a CD45 which is moderate to dim to negative. Now how do we call something as moderate to dim to negative? Mostly it is based on a cell which has a known characteristic. So we know that CD45 has a bright, the lymphocyte has a bright CD45. So anything left to it would be moderate, more left to it would be dim, and more left would be negative. Some people go by the logarithmic score. So 10 to the power 4 is bright, 10 to the power 3 is dim, 3 is moderate, 2 is dim, and anything between 1 and 2 would be negative. So it depends on the cell, known cell, how do we call something dim, bright, or moderate intensity. So this is the dot plot that I am showing you. You can also get the contour plots. So these contour plots basically denotes that the maximum intensity of this cell is at this point, and the entire cells are myeloid or the neutrophils, but the maximum intensity is over here. Again, CD45 and side scatter you would see the same way. So these are the contour plots. So each and every type of plot would give some or the other kind of information based on the experience would we see it, but mostly used are the dot plots, this ones. Does CD45 gating tell me something? Yes, CD45 is a common leukocyte antigen, and it is the first antigen with which we gate our population of interest. It is very important to know in flow cytometry what your population of interest is. Only then you would be analyzing the correct population. Now CD45 expression is different in different type of blast. Mostly this is correct. There are variations, but to learn this, in most of the cases you will find it this way only. The lymphoblast, the B lymphoblast are CD45 negative to moderate positive and has a low side scatter. So if you see this graph, so these are the lymphocytes, this is the blast, the cells of interest. So This is moderate to negative. T lymphoblast may have a CD45 expression which is moderate. Sometimes it is same as normal lymphocytes. So this blast population you will see somewhere over here. Myeloid blast are again CD45 negative to moderate, but these have a moderate to higher site scatter. So this is the lymphocyte with a low site scatter. This is the blast population, the myeloid blast population, which is moderate to negative, and the site scatter is moderate, not very high site scatter as the granulocyte or the eosinophils, but a moderate kind of site scatter. And the APMLs or the acute promyelocytic leukemias or the FAB classification AML M3s as they were known. So these would have a classical teardrop like uh, blast population, which would be again moderate to dim CD45, but the side scatter would be moderate to high, because these are, so we all know APMLs have lots of granularity, brightest MPO positivity, activity, the myeloperoxidase activity, and we may also see multiple OR rods or what we call as faggots in our morphology. So because of this complex granularity and the complexity of the cell, these acute promyelocytic leukemia would give you this teardrop like appearance. Again, I would like to mention this is not a rule, but mostly you would see these patterns. There are always variations possible. The another thing that we put in our tubes is a negative control. So negative control is nothing. We have not put any dye or any antibody in these fluorochromes. Why is it important? Because sometimes the cells have their autofluorescence. They emit certain wavelengths of their own. So for example, in this FITC PE, we have not put any stain. Still these are giving me some emission, and they are over here. So whenever I have to call something positive for this blast, they will have to be above this range. Same way for a APC, it has to be somewhere above this. So we put a negative tube, usually a blank tube with only CD45 in it, CD45 to gate the cells of interest, and rest all fluorochromes are left blank to get where are our negative populations. Also, there are certain internal controls which are very important, which become those for me are the most important when I have to call something as positive or negative. So for example, CD13 we all know is present in the myeloid cells. Now if I have to call something positive, it will have to be of somewhere of this intensity, or just a 1 log difference from this intensity. CD5 we know is present in T cells, so these are the T cells. So anything if I have to call positive should at least fall in this area. Other than that, everything is negative. Then again, CD33 if you see is positive in myeloids. HLA-DR is one marker which you might see in mature B cells also. So here HLA-DR I have two population, the negative population, I am talking about the blue population. So negative blue population are the lymphocytes which do not have DR, most likely T, NK, etc. cell. The positive blue population are most likely the lymphocytes, B lymphocytes. So here I know that these green cells, which are my cells of interest, are positive for HLA-DR. Now this color coding is again not specifically to, there are no such guidelines for this color coding, but I would again suggest to keep the color codes same for the same kind of cell in your lab so that there is less confusion. What we usually follow is a green or red color to the cells of interest, a blue color to the lymphocyte, a purplish maroonish color to the purplish color to the myeloids, maroonish color to the monocytes. So these are certain colors that we follow in our lab, and it is entirely up to the pathologist and the hematopathologist, the technicians, to choose their own colors, but the advice is to choose the same colors throughout all your samples so that there is very less confusion. So most of my cases you would see that the green color is the cell of interest, the blue color is the lymphocyte. Now, once I have told you all these gates and everything, now let's actually see what we analyze and how we come to a diagnosis. With each case, I will try to emphasize on one or two things, and hopefully, this would be helpful. I have taken only the normal cases, I have not gone into any rarer forms. Um, so this is the 8 years old child presenting with high grade fever, leg pains, increased WBC counts, anemia, thrombocytopenia with circulating blasts in the peripheral blood. So with this, I know it is acute leukemia, and most likely a cytochemistry should be done. That is the MPO, NSE, pass, etc. But in case the cytochemistry is not done, you get the sample for flow cytometry and you process it in your lab. So as I told, you do a singlet gating, all the doublets have been removed, so I am not analyzing anything that is not of my interest. Then on the CD45, you see there these blue cells are in the lymphocyte window, the purple cells are in the granulocyte window, and these green cells are my cells of interest. Now, why do I call my cells of interest this? Because I know I am dealing with the acute leukemia. So in acute leukemia, as I have already mentioned, the blasts are less bright or moderate or dim expression of CD45, and in this case it is a low side scatter blast. So having gated this, now I will be concentrating only on this P2, P3, P4, as the name is not important, but these are the gates which I would be looking into next. Now a crowded slide, but this was just to make you acclimatize with how we see everything on our screen. So this is the CD45, the green cells of interest. Now if you see in terms of CD117 and CD7, the green cells are in the negative column. These few blue cells, now blue is lymphocyte, are positive for CD7. What are these? These are T cells. Coming on to this plot, CD10 versus CD19. Here I see lots of cell, almost all the cells, all the blasts positive for CD19 and 10, and these are co-expressing CD19 and 10. Here in this plot, CD34 expression is there. Again, no myeloid or T cell markers are present on the green cells. That is the population of interest, the blast. HLA-DR is positive. Now CD34, HLA-DR are the stem cell markers. You have CD19 and CD10. You have TDT positive. TDT is again a marker of immaturity specifically for the lymphoblasts. And you have CD79A. MPO is negative. So when we see all these plots, what we get to know is that the cells of interest, that is the blast, are CD45 moderate to dim to negative. They are 1910 positive, 34 DR TDT cytoplasmic CD79A positive, and along with that what I have here is 66C and CD22. Now I told there are certain predictive markers or markers which would suggest me something. Now CD66C was being used earlier. Nowadays also many labs use this, but it had a good correlation with pre-BALLs having a BCR-ABL translocation. CD22 is a marker for which we have targeted therapy. So telling this and giving this information to the clinician that this is a precursor B cell ALL with presence of CD22 becomes important. So now what I have given is the lineage. Along with that, I have also given one of the predictive marker. The diagnosis is B lymphoblastic leukemia NOS or precursor B cell ALL. We have got 1910 co-expression. So this is how you would analyze a plot and come to a diagnosis. Quickly going through the second case, a similar case. A 7-month-old child came with fever and a very high WBC count. Now here I would like you to focus on two things. One is the cells of interest are 19 positive but 10 negative. In the earlier case it was 1910 positive. Again these are CD34 positive. The markers for T and myeloid are negative. But what I have put up here is this what I should say table, and what I get to know from here is that I have acquired 30,000 events. That are the total events, which also includes the doublets. Now, out of these 30,000, I removed the doublets, put a gate of singlets. I got the P1 population, that is 27,168 events, or 90.6% population. So, out of the 100% events that were captured by my flow cell detectors, I am analyzing 90% of the events. Out of that, my cells of interest are 24,817. That is 82% of the total, or 91.3% of the singlet, and so on and so forth. So sometimes these becomes important, because when to call something as positive or negative becomes dicey when the expression is in very few blasts. So for that, in our labs as a protocol, we have for any surface antibody, 20% would be positive criteria. So if I see that the percent of the parent population is 20% and above, I would call that marker as positive. And for the cytoplasmic, the criteria is of 10%. So sometimes we use this again to see whether the percentages are beyond the cutoff criteria to call something positive or negative. Now, coming back to the case, so this is a CD19 positive, CD10 negative, CD34 positive acute leukemia. What do we call we call it as a pro-B lymphoblastic leukemia or an early precursor B ALL. So CD10 has not yet come. If CD10 was present, it would have been precursor B ALL. But when CD10 is not present, we call it as pro-B ALL or early precursor B ALL. Usually we would find a MLL rearrangement in such cases, and it is almost always found in infants. Coming to the case 3, a 13 years old male with complaints of fever, weakness and fatigue, hepatosplenomegaly, lymphadenopathy, CT thorax showed anterior mediastinum mass. Now hemoglobin of 9, total count 84,000, blast 78%. We know it is acute leukemia. Now this is something which I would like you to keep in mind, that is anterior mediastinum mass. Now we go on to the flow cytometric analysis. What we find here is these are the lymphocytes, the myeloids and our cells of interest, the P2 population. CD7 is positive. Now CD7 is a T cell marker. So CD7 positive is a T cell marker. Again 19 is negative. You have some 10. CD99 is positive. Surface CD3 is positive. Now see, there lots of cells are surface CD3 negative, but more than 20% cell would be CD3, surface CD3 positive. Now as surface CD3 is positive, cytoplasmic CD3 will also be positive. So cytoplasmic CD3 positive, TDT positive, the myeloid markers negative, CD5 again a T cell marker is positive, the B cell markers negative. 4-8, if you see, normally we get 2:1 ratio. Here the ratio is altered. There are hardly any cells which are 8 positive. Entire blast population is 4 positive. So the 4-8 ratio is altered, and you have CD2 positive. So CD2, CD3, surface and cytoplasmic both, CD5, CD7, TDT, CD34 and CD4 positive. So all the T cell markers are positive. The diagnosis is T cell acute lymphoblastic leukemia. Now giving out diagnosis of T cell acute lymphoblastic leukemia is good enough. You might go into putting it as a cortical or a medullary or a pre or a pro T cell leukemia, but it is not very much required. But depending on the markers present, you can always give whether it is a cortical type or a medullary type, or a pre type of acute T cell lymphoblastic leukemia. But what you must keep in mind is there are certain categories which mimic, I should not say mimic, which also correspond to similar markers and would give you similar picture in flow cytometry. First is a new entity which has been added, that is ETPALL, which is around a decade old entity with not so good prognosis. Now ETPALL, what you have in ETPALL is the T cell markers are present. You would have one or two myeloid markers or the stem cell markers. Then along with that, you would have CD1A negative, CD8 negative, and CD5 would be dim. So with all these markers, you diagnose ETPLL. Again, I am not showing the plot because it would be a bit um, for the pathology students, the postgraduate students. Understanding ETPLL might get difficult, but you must definitely know the entity and the markers associated with it. The another entity which is hepatosplenic gamma delta, which is a T cell lymphoproliferative disorder, may look like this T cell acute lymphoblastic leukemia, but in that you put TCR alpha beta gamma delta, and these are two markers, TCR alpha beta and TCR gamma delta. So with these two markers you would find all these T cells, the cells of interest are TCR gamma delta. And if you look into the biopsy, the bone marrow biopsy, you would see the intrasinusoidal T cells, which is a clue to the hepatosplenic gamma delta lymphoma, which is a TCLPD and not an acute leukemia. Third, sometimes ALPS would also mimic a T cell acute lymphoblastic leukemia. That is, so it is important to differentiate between these entities. But giving out a T cell acute lymphoblastic leukemia is more than enough on flow cytometry. Coming to case 4, a 38 years old male with complaints of fever, weakness and fatigue, no organomegaly, no lymphadenopathy, hemoglobin of 8, total count very high, blast 75%, and what do I see here in blast is a thin, slender or rod and a prominent nucleoli. So most likely it is a myeloid leukemia. So why I am calling this most likely? Because rarer cases we have seen or rods in the lymphoblasts also, but it is very rare. Most likely, almost we can be sure that this is a myeloid blast. What more can we do is we can put a cytochemistry stain of MPO and it will highlight the peroxidase activity and we will get the, we can call it as the AML. But again, as I have mentioned earlier, flow cytometry not only gives you the lineage, but more information is given. So if you go through the WHO, AML has so many categories and those categories can be deciphered only after doing a flow cytometry. Even the FAB classification had M0 to M7, and for knowing those M0 to M7, again, morphology was not sufficient or cytochemistry was not sufficient. You would have to do the flow cytometry would have been the test of choice. So coming on to the flow plot analysis, CD45 dim to moderate, side scatter again dim, low to moderate side scatter. What we find here is CD117 and CD34, the two stem cell markers positive or the immaturity markers positive, 1019 negative, 7 negative, so no T cell markers, no B cell markers, 13 positive, sorry for this crowded slide, but 13 positive, 33 positive, and what we have got here is cytoplasmic MPO positive and HLA-DR positive. So HLA-DR 13, 33, CD34, CD117 and cytoplasmic MPO positive. This is a classical case of acute myeloid leukemia NOS. Now, once we get this, usually we tend to put 14 and 64, which are the monocytic markers, just to see whether there is any monocytic differentiation also present along with the myeloid blast. So you could have two types of blast, the myeloid blast as well as the monoblast. Depending on that, you would call it as an M4 or M5, whatever. So, but in this case, we know that 1464 is negative. Rather, it is showing a very good maturation pattern, and most of the cells are negative for 14 and 64. for diagnosis becomes acute myeloid leukemia NOS. Now, by telling that it is acute myeloid leukemia NOS, what we are, the information that is being given to the clinician is you need to do further tests, which are cytogenetics, so conventional karyotyping and FISH, and second is the molecular studies for various NPM1, FLT3, etc. So once we get the information from the cytogenetics department or the molecular department, we would give a comprehensive diagnosis, and nowadays all tend to give a comprehensive diagnosis, that is acute myeloid leukemia NOS with presence of normal karyotype and say FLT3 mutation. So because this holds a great importance in the prognosis of the patient. Coming to the next case, a 32-year-old male complains of weakness, fatigue, ecchymotic patches. Now here you would see that the total count is very less, but whatever we have are the abnormal promyelocytes, 90%. We can see the facets that are multiple or rods crisscrossing present in the cytoplasm of these blasts. Now, as I had mentioned, we get a teardrop cell-like pattern. So these are our cells of interest. CD117 positive, cytoplasmic MPO nicely positive. Other than that, usually 34DR are negative in APMLs. As you can see here, 34 is negative, DR is negative. You get the myeloid markers 13 and 33, and you give the diagnosis of APML, and you further suggest for PML RARA studies either by FISH or by molecular techniques. Just to remember in this case, two things. One is this teardrop pattern, APML. Second, 34DR negative. Now 34DR negative can also be seen in NPM1 or FLT3 mutations. So all 34DR negative myeloid leukemias are not APMLs. APML diagnosis can be made only if you get a PML RARA translocation. Coming to the next case, 39 years old female presented with leukocytosis and bicytopenia, again blast 42%, no lymphadenopathy, no organomegaly, bone marrow, 60% blast, acute leukemia. What type of acute leukemia? Now note the markers. So CD13 HLA-DR positive. What I have here is CD19 and 10 co-expression. So one is CD13, one is CD19-10 co-expression. You have CD34 positivity. So CD34 HLA-DR positive. It is a immaturity marker, acute leukemia done, but we have one myeloid marker, 1910 are the B lineage marker, and what I find here is cytoplasmic MPO, which is a myeloid marker. So what do I have here? Going on to another plot, well, I'll not go into the details. One more important thing which I want to point out here is CD79A, cytoplasmic CD79A positive. So three markers or four markers which I want to emphasize in this are 19, 10, cytoplasmic MPO and CD79A. What is this? This is a biphenotypic leukemia which has B as well as myeloid. Now how do we call something a biphenotypic? So there are EGL scoring system. So you give usually points based on this, and accordingly you would diagnose. But the better criteria which we follow is, so usually EGL is not followed, but we follow the WHO guidelines for assigning more than one lineage to a blast. Myeloid, cytoplasmic MPO should be positive, or you should have at least two markers of monocytic differentiation, which are NSE, CD11C, 1464 lysozyme. So any of two markers out of this five if positive, then the lineage assigned to the blast is myeloid. T lineage, cytoplasmic CD3 positive, you assign as a T. B, CD19 strong, that is bright, plus one of the following with strong expression, CD79A, cytoplasmic CD22 or CD10. Or if you have a weak or a dim CD19, then at least two should be present, CD79A, cytoplasmic CD22 or CD10. Going back to my case, we have CD19. I would call this a strong CD19 with one marker that is 10. Also, I had the second marker that is CD79A. So B lineage assigned to this blast. Along with that, I have cytoplasmic MPO. So I assign myeloid also to these blast. So this is how we come to the diagnosis. Coming to the next case, 1-year-old child, fever, eczema, rash, spleen, trisomy 21 and circulating blast like cells. So trisomy 21 here becomes important. What we get here is CD45. I have not put up all the plots because the clinical history, the morphology was suggesting to me what I am looking for, and what apart from other markers we put CD61 and CD41A. So these are the markers which would give me a diagnosis of acute megakaryocytic leukemia, or as FAB classification, a AML M7. Now in these cases again you might have a CD34 positive or negative. The 45 would be dim to negative. So again, how do I come to a diagnosis? I take the clinical features, trisomy 21. I take the morphological features, that is presence of the cytoplasmic protrusion on my blast, and then putting my markers accordingly and giving a lineage diagnosis of a acute megakaryocytic leukemia. Coming to next case, 12-year-old child with fever, breathlessness, again blast 35%, so acute leukemia. Dim to negative CD45, lower side scatter, most likely lymphoid blast. 1910, very nice co-expression, so 19 bright with CD10, B lineage we have assigned to it. But what do we get here more is myeloid markers, CD33 and CD13. Along with that, HLA-DR, CD79A, TDT and all immaturity markers are positive. So is this a mixed leukemia? No, because to call something as a mixed leukemia, if I want to call this as a B myeloid, I will have to have cytoplasmic MPO positive. But when we see cytoplasmic MPO, it is negative. Only TDT is positive. So this is not a mixed leukemia, but what it is a precursor B cell ALL with aberrant expression of CD13 and CD33. So this would then have some value. How? Because CD13 and CD33 expression on pre-B cell ALL again may have the translocation 922, that is BCR-ABL translocation. Similarly, if acute myeloid leukemia, you might find CD19. So only CD19 and no CD10, CD79 or cytoplasmic CD22. We have got only CD19 and all the other myeloid markers. So I will not call it as a biphenotypic or a mixed leukemia. I will call it as a AML with aberrant expression of CD19. Now, giving this information, what I know is most of the time these come out to be positive for translocation 821. So with a diagnosis of AML with CD19 aberrant expression, the cytogenetics team gets alert and would look for translocation 821. So there are certain markers which would tell you about what the cytogenetics or molecular diagnosis is going to be. Another important prognostic that we do in our flowcytometric analysis of all B ALLs, precursor B cell ALLs, is a DNA ploidy analysis. Now, again, I am not going into the details of it, but this is a very good article, so I have picked it up from the internet. And so these are my singlets, these are my lymphocytes, and these red colors are the blasts, and all blasts are CD19 and 10 positive. Now what do we do here is we put a FX cycle die, which gives me the graphs according to the G1S and G2M phase. Now this is for the lymphocytes, this is for the blast. How do I calculate the ploidy? So we take the mean fluorescence intensity or the MFI. Now if you see, this is my lymphocyte this is my blast, and when I divide the intensity of lymphocyte with the intensity of blast, I get a DNA index of 0.58, and that is haploid. I'll go to the next slide and then come back to this. So DNA ploidy analysis. So this study was done at Tata Medical Center, and there was a good correlation between the chromosome number on the blast and the DNA ploidy by flow cytometry. So if we have a ploidy of say 0.55 to 0.69, then the chromosome number on the blast is 24 to 29. If I have a DNA ploidy of say 1.16 to 1.39, then the chromosome number is 51 to 65, and I call this as high hyperdiploid. When the DNA index is between 0.96 to 1.05, I have the two sets of chromosome, that is 46 chromosome diploid. When the DNA ploidy is 1.80 to 2.28, it is near tetraploid. That means there are almost about 4 sets of chromosome, so the chromosome number is 81 to 102. And how do I do this on a flow cytometer? I'll come back to this slide. So in this graph we can see the blasts and lymphocytes are almost on the same intensity. So if we divide, we'll get a value around 1, and according to the table it is a diploid. These blasts have just a bit more intensity than lymphocytes, and here the DNA index is 1.10, low hyperdiploids. Here the DNA index is 1.26, that is high hyperdiploid. In this last graph, you see two peaks of blasts. So there are twin peaks, DNA index 0.86 and DNA index of 1.46. So DNA index of 0.86 is low hypodiploid, while DNA index of 1.46 is near triploid. So basically this happens because of endoreduplication, and well, again I will not go into the details, but here a cytogenetic analysis is it comes to aid. Now by doing this DNA ploidy, we are giving the information about prognosis at the very first step of diagnosis. So, and this correlates very nicely with the karyotyping. However, the gold standard is karyotyping, and karyotyping for counting chromosome number has to be done in almost all the cases, but at least we get an idea from the flow cytometric DNA ploidy analysis about the what is the ploidy, and if you study, you would know that high hyperdiploids have a good prognosis, or a haploid has a bad prognosis. So we give the information about prognosis at the very stage of flow cytometry, because a karyotype would take time. So flow cytometry gives us the result the very same day. Coming on to another important application of flow cytometry, that is measurable residual disease. Now what is a measurable residual disease? Earlier we used to call it as minimal residual disease. It describes the disease that is detected only by laboratory techniques, more sensitive than morphology. So historically we have been giving a morphological complete remission when we have less than 5% blasts on bone marrow. But by using techniques such as flow cytometry, PCRs, etc., we can look into much more cells to know whether even if the disease is present less than 5% or not. So anything which can be detected other than morphology is the measurable residual disease. Now, for example, this red line indicates not in remission. So any number of blasts above this, we would say this is not in morphological remission. Any cells less than this, we would say it is in morphological remission. But although it is in morphological remission, there is some residual disease remaining. Now how is this important? So these residual cells are responsible for the relapses. So the aim of any treatment is to get zero blasts. So now ideally that might not be possible, So zero clonal cells might not be possible, but if you see here, when you go to the proportion of 10 to the power minus 6 or 10 to the power minus 7, if the disease is less than this, the chances of relapse are almost nil. Even if you have disease in this submicroscopic, that is 10 to the power minus 2 to 10 to the power minus 6, which is detected by various modalities, flow cytometric being one of the most important, the relapse is very, very, very late. And in some instances, the patient might not relapse, or the time period between the remission and relapse is too large. The patient gets a good quality life for many, many, many years. But if the microscopic disease is present, then the MRD is and the level of 10 to the power minus 1 or minus 2, you would get early relapses. So what are the methods of MRD assessment? Morphology, multicolor flow cytometry, cytogenetics, PCRs, and newer methods such as next generation flow cytometry, next generation sequencing, or ddPCRs. Now I would stick to multicolor flow cytometry, and the most used disease or the flow cytometry in which disease we use it most is the BALLs, and now it has been a part of treatment to see for MRD at post-induction and post-consolidation. MRD analysis for TALL has also been validated and established, and most of the centers are doing it. AML MRD still very few centers in India are doing it, but still again AML MRD is also very, very important. To do MRD analysis, now I am going on only BALL MRD. I'll tell one or two cases. I will go through one or two cases. But before going to that, what I want to emphasize is, now when you give a treatment to a BALL patient, the blasts will go off and the marrow will regenerate. So this regenerating bone marrow will have the cells right from the most earlier stage to the final stage. These are not blasts, these are not abnormal cells, but these are immature cells. So how do I differentiate between an immature cell and a blast? So the knowledge of normal maturation patterns becomes very important, and by running almost 15 to 20 normal bone marrow samples, we prepare templates, and according to these templates we would then predict whether MRD is present or not. So CD34 to CD45, if you see, these are the stage 1 hematogons as we call them. Stage 2 are the blue hematogons, stage 3 are the purple hematogons. CD38-45 would have this maturation pattern. So any cell falling in this template, I would call it as measurable residual disease. 10 to 20, you get a good waterfall pattern. This is the maturation pattern. And CD10, CD19, you get this type of maturation pattern. So knowing this maturation pattern becomes important. I'll run through two cases. A 50 years old female, morphological remission. There were blasts around 4% in the bone marrow. We did a MRD analysis. Now here you can see CD19 was 1.76% cells were only CD19 positive. Now these might not be blasts. There are normal hematogons also present in this. But when we did this, so now in the previous slide I saw there was a 4538. Ideally it should have gone like this, but what we see here is this CD19 positive cells are not going like that. They are present over here like this. Again, if you see here, there are lots of CD34 positive, CD19 and CD34 positive cells. CD123 is dim, CD73 is overexpressed. So all this indicates to me that this red population is the measurable residual disease. Now why do I say it is measurable? Because I can quantify it and tell to the clinician that 1.5% abnormal clonal B blasts are present in the bone marrow. So this is how we use MRD. Another interesting use, now 18 months old child, normal karyotype. Now here you see there were cells which were with this blue arrow. You would see these are, I'm not sure what, lymphoid cells, but they do not have cytoplasm, look very open, chromatin. And then there are these cells which are larger, atypical looking. Now we are not sure what to call this. So there were hematogons slash query blast 7% and most of the cells were of lymphoid origin. So in these cases, giving out a morphological remission becomes very difficult, whether these are blasts, whether these are hematogons, and so we do not call it as a morphological remission. But when we go to the MRD analysis, we have 32% CD19 positive cells, but all showing normal maturation pattern. See this maturation pattern, this waterfall maturation pattern, all were showing normal maturation pattern, and no cells are present in this templates which are supposed to be the measurable residual disease. All within normal range, everything was within normal range, and therefore here, although we had some atypical looking 7% cells in the bone marrow, what we gave out as diagnosis was a negative MRD. Now this is very important in patient care because now it depends on the MRD whether there would be an intensification of treatment, whether the prognosis is good, the prognosis is bad. So giving out a negative MRD report becomes very important for that patient. Coming to flow cytometry in MDS. Now MDS, again, the diagnosis is based on the cytopenias, the karyotypes, the molecular rearrangements, and flow cytometry has a very less role to play. Although there have been many publications, many studies, but MDS is not routinely diagnosed in day-to-day practice in a hematology lab. But flow cytometry is very useful in diagnosing dysplasia in that terms. So, for example, you know that the MDS neutrophils are hypogranular. So when I say hypogranular, the granules are less, the complexity is less, the side scatter would be low. So if I compare it to a normal marrow or a normal peripheral blood, the myeloids are placed on a specific position, but the neutrophils of MDS would be lower to that what a normal template would show me. Again, when I know the normal patterns, I can get to know the abnormal pattern. So looking into the neutrophils again, so if we go with CD13 and 16, you have this classical, yes, what I should say, Nike or a tick mark pattern, 13, 16. But when we see in an MDS sample, we know something is not correct over here. And this gives me a clue that there is dysplasia. If you see 1611B, a normal nice pattern, here there is something is missing. These cells are being overexpressed. All cells are not maturing. There is some maturation arrest. Similarly, 1311B, see these cells are not present over here. So knowing normal maturation pattern and comparing your sample would help in telling you whether dysplasia is present or not. There are certain scores, the Ottawa score, which helps in diagnosis of MDS. Again, not going into details because this is not usually used in day-to-day practice. So immunophenotyping in leukemias, MRD and MDS, we need to know 4 things. One, there can be gain of antigens which is not normally expressed, that is aberrant expression. Increased or decreased abnormal expression, asynchronous antigen expression, for example 1910 co-expressing, and abnormal homogeneous expression of one or more antigens. So knowing this, knowing the normal maturation pattern, knowing the normal markers present, we can very well diagnose leukemia, MRD or MDS. So here this is all about the leukemia. I would quickly move to chronic lymphoproliferative disorders. Now again, CLPDs, not much can be diagnosed on flow cytometry. There are few entities which we can diagnose on flow cytometry. For most of the diagnosis of lymphoid neoplasms, that is mature BET and NK cell neoplasms, we rely on the lymph node biopsies. But how do we approach to this, or what is the role of flow cytometry? So first is diagnosing whether it is a reactive or a lymphoma. Second would be lineage or subclassification. Third, again, as prognostic markers, I had emphasized in leukemia, there are many prognostic markers which give information in CLPDs also, and MRD is also being done in cases of CLL. although in a very few centers, but it has its role. So again, panel designing very important. As I told, Euroflow has its own lymphoid screening tube. Not going into the details. You have to develop your own panels according to the need, according to the sample. The samples are similar. The peripheral blood, bone marrow, cavity fluids, FNACs, and again biopsies from lymph nodes, spleen, and skin you might get. You will have to tease it in a specialized instrument. You make a cell suspension and then run it on a flow cytometer. How do you approach to a BCLPD? So first, what we do is CD19 and CD45. Now, a CD45 gating in acute leukemia was towards dim and negative side, but here a CD45 would be equally expressed as of a lymphocyte because these tumors arise from mature lymphocytes. So CD45 is bright. As these are BCLPDs which we are talking about, CD19 is also positive. So once you get something from the clinical assessment, something from the morphology looking like a CLPD, you put CD19, CD45, you get CD45 and CD19 expression. You presume it is a CLPD and move forward. The first marker that we put is CD5. If CD5 is positive, we go down this tree. If CD5 is negative, we would do further, which I will come in my next few slides. CD5 positive, look for CD200. CD200 positive is if so CD200 positive, most likely the diagnosis is CLL. You would find atypical lymphoid cells in your morphology with smudge cells. CD20, if it is dim, it is classical CLL. If CD20 is bright, it is atypical CLL. If CD200 is negative and CD20 is moderate, most likely it is a mantle cell lymphoma. Coming on to a few of the cases, I will just go through it. 65 years old male, asymptomatic, routine checkup revealed high WBC count with absolute lymphocytosis. PBS examination, atypical small lymphoid cells with clump chromatin and many smudge cells. Singlets, now here you can see these are doublets, not my interest. I look into the singlets. Now green, my population of interest, the cells of interest. See, the brightness is more than that of the neutrophils. In acute leukemia, what we were seeing was all entirely over here. In CLPDs, what we will see would be entire towards the right hand side of the myeloid, that is moderate to bright expression of CD45. Now here we put one more gate and that is of a CD19. So all my CD45 cells go and I have to look, now my population is interest is only CD19. So I gate further as CD19 and further I would look only into the CD19 positive cells. What do I see here? CD19 positive cells are co-expressing CD5 and CD23, that is these are CD5 positive. So CD523 co-expression, CD519 co-expression and CD200 positive. So with this I come to know that this is a CLL. The most important thing in diagnosis of a BCLPD is the kappa lambda restriction. Now ideally a normal mature B lymphocyte there would be a ratio to kappa and lambda, but here what I see that entire population of interest is kappa restricted or expressing only kappa, no lambda. So kappa restricted. So I know that these are clonal cells, 519, 523 co-expressing, 200 positive, the diagnosis is CLL. Based on CD20 we can say whether it is a atypical CLL or a classical CLL. If CD19 is positive but CD5 is negative, then what is the next marker that we will look into? We will look into CD10. So now see, if CD10 is positive, what I am talking about is CD19 and 10 positive. Now if you remember, CD19 10 positive cells are also present in my pre-B acute lymphoblastic leukemia. But here what we are talking of, a bright CD45 expression. So that has to be kept into mind. Next, what I will look into is whether my cells are small or large. Now how do I see it? Forward side scatter. Forward side scatter is directly proportional to size. So low forward side scatter, small cells, CD38 dim, 19 10 positive, 5 negative follicular lymphoma. 10 positive, high forward scatter, that is larger size, most likely the diagnosis is DLBCL. But on flow we usually do not diagnose a DLBCL, or we can diagnose a DLBCL, but it is better to do it on a lymph node biopsy. CD10 negative, high forward side scatter, you have the DLBCLs. Then again you can put BCL6 MUM1 markers to show whether these are activated B cell or germinal B cell DLBCL. If CD10 is positive, you have CD38 bright, and looking into the morphology, you can come on to a diagnosis of Burkitt's lymphoma also. A case, 60 years old male, bilateral pedal edema, hepatosplenomegaly, multiple lymphadenopathy, high absolute lymphocyte count, atypical lymphocytes with cleaved nucleus. Now morphology can suggest you what the diagnosis is, but flow cytometry is confirmatory. And here you can see CD19 and 10 co-expression, but this co-expression is on the cells which are CD45 bright. Had this CD45 or cells of interest been here, I would have called it as acute leukemia. But because CD45 are present, it is brighter. This is a CLPD with 1910, and here you can see kappa restriction. The other B cell markers 2022 and 79B is also positive. The diagnosis is follicular lymphoma. If 5 and 10 both are negative, what next? So most likely the diagnosis goes towards the hairy cell leukemia or the lymphoplasmacytic lymphoma or marginal zone lymphoma. Marginal zone lymphoma is something which overlaps everywhere, can have 5 positive also sometimes. So marginal zone lymphoma is mostly a diagnosis of exclusion. Then if 5, 10 are negative, you put in markers such as 11C, 103, 305, 25. You get all these markers, it is a hairy cell leukemia classical. If CD25 is negative or one of the 2 of these 4 markers are negative, you call it as hairy cell leukemia variant. With MYD88 mutation, it is a LPL. And marginal zone lymphoma, I told it could be nodal, extranodal, splenic marginal zone lymphoma. Depending on that, you can get a varied immunophenotype for a marginal zone lymphoma, and mostly it is a diagnosis of exclusion. 37 years old male, high grade fever, pneumonia with consolidation, splenomegaly, pancytopenia, atypical cells with hair like projections. Now pancytopenia again important, because the bone marrow cannot release the cells because of the fibrosis present, you get a pancytopenia, but you would find these atypical cells which have hair like projection. So as I told you, bright CD45, then CD19 gating, and when I know CD5 is negative, CD10 is negative, I move directly to the markers of CD11C, CD123, CD103 and CD25. All these markers positive, 103, 123, 11C and 25. I know this is a case of hairy cell leukemia. Splenomegaly is a clue, pancytopenia is a clue, hairy like projections is a clue to go forward with what tube we are going to put. Coming to another mature B cell neoplasm, that is the plasma cell neoplasm. I am not going into the details for this, but there is a role of flow cytometry in plasma cell neoplasm, that is prognosis of multiple myeloma and its precursor lesions, and very important, treatment or auto stem cell transplant response monitoring, that is myeloma MRD. And now you have next generation flow cytometries which looks into more than 50 lakh, more than 1 crore events, and you go deeper and deeper into measuring the residual disease. What is important here is to know what is a normal plasma cell and what is an abnormal plasma cell. So if you would see on an abnormal plasma cell, you will never see a CD19. CD45 is very dim or almost negative in more than 90% of the cases. CD27 is positive in almost 100% of the normal plasma cell. So knowing this, we do the analysis of plasma cells. Another important marker is kappa lambda restriction. So either kappa restriction or lambda restriction indicates toward a clonality, and by looking into all this we can come to whether the abnormal plasma cells are present or not. The diagnosis of plasma cell per se is not done by flow cytometry. Those are the CRAP criteria. You look into the radiology, you look into the biochemistry, the FLC ratio, the IFE, and the bone marrow plasma cells, and that is more important in diagnosing plasma cell. But yes, prognosis and treatment response, there is a definitive role of plasma cells, and almost all multiple myeloma patient follow up with a flow cytometry along with FLC and IFE. So coming to my last slide, I have talked in depth about leukemias, and most of the lymphomas, and as I told, flow cytometry has a limited role in lymphomas because most of the diagnosis is on tissue. So IHC is a better model, better modality. But as I told in my earlier, that almost all these entities have an the flow cytometry has an application in almost all these entities, but all those within this box, definitely a big role of flow cytometry, and the acute leukemias and the CLPD, specifically the chronic lymphocytic leukemia, is diagnosed and lineage characterized only on the basis of flow cytometry. So this was all about the malignant tumors or the tumors of hematopoietic and lymphoid tissue or the hemato-onco cases. A day after tomorrow, I have my next talk. In that, I would be concentrating on the benign aspects of the benign hematology applications, the flow cytometry application in the benign hematology. Well, thank you very much. I think I have exceeded the time, but anyways, these are again the centers which have given me everything which I know about flow cytometry. I would like to specially thank Dr. Rakesh Demde for helping me out with this presentation. He shared few of the slides we have made together, and few of the cases we have discussed together before putting into this presentation. Yeah, thank you very much.
No time exceeded such a wonderful lecture. We could have gone for another hour, no issues on that. Wonderfully presented. Before I conclude, let me just share some questions from the YouTube. Dr. Nilesh Kapadia from Ahmedabad is a very senior consultant there. He would like to first, he says, excellent case and correlation with molecular. Wonderful presentation. Then is a question, aberrant dim or bright expression of specific markers in any specific type of disease?
Yeah, there are quite a lot. So for example, again, in CLL, a CD20, atypical CLL and a classical CLL, we differentiate on the basis of the brightness of CD20. So, but as this talk, again, I would say I put it very basic, not going much into bright or dim. But yes, almost all the markers in a report, we give it out whether there is a dim expression, a moderate expression, or a bright expression, and this in total gives us a diagnosis. A blast would never have a bright CD45 expression, it would always have a dim to negative. CLPD cases, mostly you would have a bright CD45 expression. The expression patterns, the normal maturation patterns depends on these dim to moderate to bright expressions. So definitely these is very important, and anybody who is reporting a flow cytometry must always include the expression pattern along with the marker.
Correct.
I hope I have answered the question, because in every case I could not go into what is in which markers would be dim or which markers would be brighter. Yeah.
Right. Professor Ashok Malik is a very senior professor. He was my teacher as well. He's from Middle East, and he says, well explained through individual case presentation. He says, does flow cytometry complement histopathology in a given case?
Yes, sometimes we so I did not put any case with TCLPDs on purpose, because then again flow cytometry diagnosis for TCLPDs is rare. But yes, we do look into certain cases of TCLPDs where we put both IHC markers on the lymph node, as well as sometimes we do it on the flow cytometry, the angioimmunoblastic lymphomas or the PTCL, NOS, etc. So there are, but But usually what happens is on lymph node, certain diseases which do not come into peripheral blood or bone marrow, it becomes very difficult to do anything with flow cytometry. So the diseases which are in lymph nodes, we diagnose it on IHCs, and diseases which are in the peripheral blood or bone marrow, we go with flow cytometers.
Correct. Dr. Nilesh Kapadia says arrange a webinar on flow for non-malignant hematology disorders. That is on Friday.
Yes.
So, sir, please log in on Friday as well. And Dr. Nilesh Kapadia has a final say. Says nice explanation, made easy. Yes, I agree with him 100%. A wonderful presentation, very made easy and very nicely done up. Took a lot of time, I bet, in preparing it, because it can be seen the hard work of preparation, right? Thank you, Dr. Bhagwat, and I think we'll have you on Friday for the rest of it.
Yeah, sure.
Till then, good night. God bless you. Thank you so much. Bye. Take care. Please share the PDF, sir.
Definitely.
Right. Thank you, sir. Bye-bye.
Thank you very much. Bye.